Hello, everyone, and welcome back to Community Birth Education, your guide to out-of-hospital pregnancy, birth, and postpartum. Today is Class 3, and in Class 3, we are going to cover pushing, the immediate postpartum, and variations of normal. So let's go ahead and dive right into class. Before we talk about today's topics, we're going to review some things from our last class 2. So what are some signs that labor might be near? Remember how we talked about there might be a few things that can kind of tell you that things might be happening. They don't necessarily tell us when they're going to be happening, but that some kind of change is occurring in your body. So those things might be losing your mucus plug, or what we call bloody show. It could also be feeling very crampy, feeling very nesty towards the end of your pregnancy. It could also be having loose bowel movements, could be a sign that labor is near. Or of course, if your water breaks, that is a sign that labor is coming as well. What should you note if your water breaks? Remember the acronym COAT. So we're going to write down on a piece of paper or put in your notes app, color, odor, amount, and time. Those are 4 elements that your provider is going to want to know when you call and tell them that you have possibly had your water break. So those are some things that we'll want to note. What are the 4 elements of a physiological birth space? Remember the things that all mammals need or crave during childbirth. It is privacy, silence, darkness, and warmth. So we want to create that little birth cave for ourselves so that we can get our oxytocin flowing, all those good hormones flowing, and feel really safe and loved in our environment. So dim down the lights, put on the twinkle lights, maybe play some music, some light music, and make sure that everyone is focused on mom who is invited into the birth space. All right, let's get started. Pushing, immediate postpartum, and variations of normal. So there's a power that comes to women when they give birth. They don't ask for it. It simply invades them, accumulates like clouds on the horizon, and passes through, carrying with it a child. That's a quote by Cheryl Feldman, and I really believe that it is true. Birth is going to happen to you. If you are pregnant, you are going to be having a baby. So we can take this experience and we can really feel our power through it, and it can really change us in a very positive way as we go through birth. Or we can dread it and we can fear it, and it can be a bad experience. I don't know about you, but I personally would rather feel very empowered after my birth experience. And everyone is going to feel different, but there are ways that we can set ourselves up for feeling empowered instead of powerless in our birth experience. And we've talked about those a lot in the first 2 classes about picking your birth team, getting educated, being informed. All of those things are going to prepare us. Also, we're going to kind of look at the pushing stage and see how we have a little less control than we would think that we have, or that we would wish that we have when it comes to pushing and it comes to our baby. Remember that it's not just about the way that we do things. Our baby also has a mind of its own. Our body has a thing that it's going to do outside of our brain, and we're going to talk about all of those things today. So when we think about pushing, we first want to think about the cardinal movements. So your baby is going to go through a series of movements in the birth canal in order to help them be born. And it's really pretty amazing because your babies do this all on their own. So if we look at the diagram shown, we're going to see that our babies come into the pelvic inlet. And remember how we talked about birth station or birth positions, or like positions of the baby. So if your baby is in that LOA position, that left occiput anterior position, then they'll be kind of facing this way. So their face will face away from you, face towards your bum, and their head is going to become engaged. So your baby's first going to start to be engaged. Remember that your pelvis is widest at the top from side to side, and then at the bottom, it is widest from top to bottom. So your baby has to fit that diameter of your pelvis, and they do it beautifully by corkscrewing down and through, right? And you're thinking, wow, that's a lot to do. Yes, correct. It is a lot for your baby to do. So first, your baby's going to become engaged. When the widest part of their head has passed into the pelvic inlet at that 0 station. Remember how we talked about stations of the pelvis in class 1? Then they're going to descend and flex. So these two cardinal movements go hand in hand. Descent is the movement of your baby's head through the bony part of the pelvis and reaches the depth of the pelvic cavity. As descent happens, flexion is also occurring, aligning their head with their chin toward their chest. So your baby's going to tuck like they're going to be doing like a somersault or a cannonball or something. They're going to tuck their head in, and they're going to be at about +1 station in that time frame. Then your baby's going to do an internal rotation. So your baby rotates his or her head and body from side to side, to front to back to navigate the changing diameters of the pelvis. And it's really crazy because you can feel them moving inside of you. So they're going to be tucked and they're going to be finding that best position for them to come out and have the most room. Extension occurs when the head, face and chin are born. So as your baby comes out, you can see my baby in that little bubble. So your baby will come out side to side with their head, and they're going to still be tucked. And then they're going to flex their head out. So instead of the tucking, they're going to do the opposite so they can make way for their shoulders. So then your baby's going to do an external rotation. And this is absolutely amazing to watch. So the head is born, your baby flexes out like this, and then you watch your baby turn as they turn their shoulders so that their shoulders can be born through that widest outlet as well. So the external rotation after the baby's head is born, slight pause in the action of labor. So sometimes your baby's head is born and it could take a couple of minutes as we wait for the next contraction to then see your baby rotate during that and then have the shoulders be born. So a lot of times in the out of hospital setting, partners, people who haven't seen physiological birth in this up close and personal way before start to maybe panic a little bit because the head is born and they're like, okay, are we stuck? What's happening? No. If we are stuck, we'll talk about that a little bit later and what that actually looks like. It's not as common as you think it is, but we're just waiting for that natural rotation, that external rotation of your baby. We're not pushing your baby. We're not yanking your baby out. We're waiting until your uterus and your baby work together to turn and let your baby be born. And then the last is expulsion. So your baby's body follows the rotation of the head, and this allows the top and then the bottom shoulders to be born. So your baby kind of pops their shoulders out, and that's it. Okay, so I do have a video that I will link in the notes if you're on YouTube, or if this is sent via email, there'll be a link to this video as well. It's a really cool example. It's really quick and it's a really cool example of how the baby moves, and it's a good visual to see how your baby moves during those cardinal movements. So what's happening? What is happening while you are in that pushing stage? The woman becomes more alert and the neocortex is activated. So remember how we talked about in transition, like that late active labor transition, late transition time frame of labor. Mom really goes into labor land. So her brain waves slow way down into those delta brain waves. She is just kind of off in labor land. She's got tons of endorphins running through her. Well, once we start pushing, we're going to release more of that adrenaline hormone because she needs that energy and that oomph to get through pushing. So with that comes a more alert mama. So a lot of times you'll kind of see them not fully come back into their body, but they will kind of look around and get a little bit more serious and just seem to be kind of lights back on. Contractions slow down to allow more time for oxygenated blood to enter the placenta. So it's normal for your contractions to go from that 1 to 2 minutes apart to all of a sudden when you are fully dilated and your body feels ready to push, it could very well slow down to like 3 to 4 minutes apart. And remember, we talked about that rest and be thankful phase. So you might be fully dilated, but not yet feeling the urge to push. That's okay. That's your body giving you a break. Embrace it, take a little nap, and wait until your body starts to push during your contractions for you. And you think, oh, I can't not push. So it usually begins as a feeling of a bowel movement at the peak of your contractions. So you might not feel like all of a sudden this constant urge to push. It will probably start happening during your contraction, and just at the peak, you'll feel a little ugh, at the peak of your contraction. That is totally normal. And we wait for that to build and build more. But it might just feel like that something's in your bottom. And that's usually moms will say, like, it feels like it's all in my bottom. And I'm like, okay, well, that's probably your baby's head. And that feeling of needing to push just at those peaks. So then your body begins to push a little, and then contractions become increasingly more expulsive, and the abdominal wall and the diaphragm join the uterus. And then you begin pushing several times with each contraction. Just the way I describe it, it's really funny to my students as I describe it as throwing up out of your vagina. That's a lot what pushing feels like. The true instinctual pushing will feel like you can't not push. So it's just like when you're throwing up, when you're sick, you can't necessarily time it or like decide when you're going to throw up, but you know you're going to throw up and you can feel it coming. That's a lot how pushing is. Now, of course, it's going to be different for everybody. And sometimes when it's your first time, it can take a little while to get the groove of pushing, and that's okay. If you feel like you would like some more instruction from your provider or your doula, you can absolutely ask for that at that time. But it is best to try and let mom kind of figure out pushing on her own, even if it takes a little bit until you get the groove of it. So crowning, when your baby's head is crowning, is when you see about this much head of baby. So we'll start to see a little bit of head, and then we'll see a little more, and then this is crowning, when we're just about ear to ear and we see a full crown. So crowning can be 2 steps forward and 1 step back. So your baby is actually doing you a favor. It might feel a little frustrating at the time, but your baby's going to go 2 steps forward, 1 step back. 2 steps forward, 1 step back. And the purpose of that is to slow things down and stretch and have lots of time to stretch that tissue and stretch that perineum. So it really is helpful. Sometimes it can feel like when you haven't ever done this before, it can feel like you're not making any progress, and people will say like, oh, I can see the head, but they're seeing this much of the head. So that can either be really encouraging for moms, or it can be really frustrating because you're like, we've been seeing head for 20 minutes. What's happening? So just know that we can see head, and then it's just a nice slow rocking motion as we come to the crowning position of baby. Some things that you can do during this time, if it feels helpful to you, is you personally can reach down and feel your baby's head. Sometimes that's really encouraging to moms to feel that, and to know that, oh my gosh, my baby's head is right there. And then they get this burst of energy to push through the final bits. Or you can also use a mirror. You can put a mirror, even if you're in the water, you can put a mirror down there and you can look and see your baby's head. I find that people are either like, yes, absolutely, I want a mirror, or no, I absolutely do not want a mirror. And both of those feelings are completely valid. I thought personally that I would reach down and touch my baby's head and have this like, oh, hippy dippy moment. And when it came time, people asked me, do you want to feel her? And I said, no, I certainly do not. I just want her out right now. And that was a valid feeling. So just know that you can be open to doing that. And if you don't want to do it in the moment, that's okay too. So the head is born, and then the pause before the body, like we talked about with the cardinal movements. And nuchal cords happen in about 30% of births. So that's kind of a high number, right? And a nuchal cord is when that baby's umbilical cord is wrapped around their neck. Now, remember we learned in class 1 about Wharton's jelly and about how that cord has lots and lots of cushions surrounding it with that Wharton's jelly to make sure that it doesn't compress. So a nuchal cord is not necessarily an emergency with the birth of the head. Usually your provider will kind of feel to see if there is a nuchal cord. If they are, they just do what's called reducing it. So they just slip it over baby's head and we have a baby, bing, bang, boom, no big deal. Now, of course, sometimes the cord does get pinched, but that typically happens if we have a short cord or if we have multiple wraparounds, but your midwife will be able to reduce those and make sure that everything is good with baby. And remember, they're breathing through their umbilical cord, not their mouth. So they are not going to be like choked by the umbilical cord because they're not breathing through the umbilical cord. All right, so how can we help the process of pushing? Well, we can do a few different things. We can utilize gravity. So we want to try to make sure that we're Well, we're doing lots of different positions. Okay, not lots, but you want to make sure that you're continuing to use movement as it feels good. So, especially with first-time moms, you might want to change positions every 3 contractions or every half an hour or something like that, so that we're making space, we're rotating that pelvis, creating some asymmetry, and making sure we're helping our baby corkscrew down through the pelvis. And remember, we want to try and do positions that open the outlet of our pelvis at this time. So we can do things like hands and knees, using that gravity in a squat during your pushing phase, which we'll talk about, like not squatting during crowning, but you can do different things that can help your baby move down. What we don't want to do is just lay in the bed on our back the entire time, because now we're working against gravity. So your uterus, remember how we talked about the fundus at the top of your uterus is the strongest part of that muscle, and it's pushing down, right? And it's using gravity to expel your baby. If you're laying on your back, your uterus is pushing sideways now, away from gravity, parallel to gravity, instead of having gravity help it move your baby down. So it creates more work for your uterus if we're in a laying position. That doesn't mean that you can't rest and push some on your side, or if you feel like you need a break, that's okay. We just want to try to incorporate lots of different movement so that we can help our uterus with our baby. Keep hydrated. This is really important, especially if you are in the tub having a water birth, because you tend to become more dehydrated if you're in the shower or if you're in a hot tub. So partners, doulas, this is a job for you. Make sure that there is a nice cold ice water readily available, and try to take sips of water every few contractions or every contraction. Give mom space. So it's going to take a little bit for her to figure this out. We don't necessarily want to be all up in her grill, right? Let her kind of find the groove and decide what is best for her. Do support her in like supported squat positions or things if she needs your help physically, but don't try to like yank up a leg or do something like that while she's pushing. Cool cloth can be really helpful. So she is doing a ton of work during this pushing phase, and you'll see that she'll get pretty hot and overheated. So a little electric fan to put on her face and a nice cool washcloth, 2 washcloths. What I do is I take a bowl and I fill it with ice and I put water in it. And then I have 2 washcloths so that I can rotate them out, because she's emitting a lot of heat during the pushing phase. Sometimes moms don't want it, and that's fine, but it's a good idea to have those things readily available in case she does. And in that note, I'm also going to say, please put her hair up if possible. That was my one thing, is I had hair sticking to my face all over while I was very sweaty. If you see that she's got kind of hair all up in her face and stuff, throw it up in a bun, throw it up in a ponytail so that she doesn't have to worry about that while she's working so hard. So try to avoid coached or purple pushing. So that's when we go, push, 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 and we're yelling at her and we're telling her to push to 10. If there is a reason that maybe we need to expedite the process and we need to push a little more, your midwife or your provider will make sure that they communicate that to you, and then they will help her with that process. We as bystanders, so partners, doulas, we don't necessarily need to yell, push at them. It's not the Super Bowl. She's having a baby. She knows that she needs to push. And we want to try to avoid the purple pushing, that holding your breath and pushing down as hard as you can, like you see at the movies. That's not necessarily the goal. The goal would be to let her kind of figure it out the way that is best for her. So for some women, yeah, that's holding your breath during those contractions and during those pushes. For other women, it'll be letting out some air or letting out some noise. I will say, as a caveat to that, is we want to try to stay away from those high pitches, those that we talked about. We want to try to stay nice and low during those pushing times, so that we're sending all of our energy down low. But other than that, you know how to breathe, you know how to push. So we want to make sure that we're not forcing you to like bear down for an extended period of time. Remember, 2 steps forward, 1 step back. Sometimes the process takes a little while, and that's okay. It can take a couple of hours to push out a baby. That is absolutely normal, especially the first time. And then trust the process. It's hard because during pushing, you don't see your baby. Like, we can't see your baby from the outside. So it's hard to kind of gauge like where baby is and are we almost done or things like that. Definitely don't ever tell the birthing person you're almost done or anything like that if you don't know those for sure. Just keep telling her how wonderful she's doing, that she's doing great, that she's listening to her body. All of those really encouraging words can be really helpful, and trust that she is moving her baby down. All right, positions for pushing. So instinct is key. So first and foremost, it's got to be something that the birthing person feels like is a good feeling for them. Like they feel like they're making progress in that position, or that's what they naturally gravitate to. Some examples, like you can see on this illustration here, include the birth stool or the toilet. Remember, we call the toilet the dilation station. It is a great place to push a baby out. It's got you are nice and wide and open. Your pelvis is nice and open, and your brain really thinks about like, okay, I'm on the toilet. This is where I normally let things go. So it can be really helpful. And you can use a little birth stool and you can lift one leg up and then you can switch legs to create some asymmetry on the toilet. It's a really good spot. But if you don't necessarily want to be on the toilet, you can also use a birth stool. A lot of birthing centers will have this. It looks like the same shape as a toilet, but you're not in a toilet. And that can be really helpful. You can do things like squatting. Remember, we talked about squatting during pushing is a great way to move your baby down. Those deep squats open the top of your pelvis. So we want to do that kind of earlier in our pushing phase. As we get to the end of our pushing phase, the deep squat can put a lot of pressure on your perineum and create more tearing. So we want to kind of avoid that position for crowning in the actual birth of your baby. But if that's also what feels good, then that's fine. And then you can also, of course, use the birth pool or the birth tub. That is a great place to have a baby for many different reasons, because it's hard for people to get their hands down there and kind of mess with what's going on with you. It creates a lot of like fluid. It creates a lot of counter pressure with the water, and it just feels really nice, and it can help with tearing in the pool as well. And it just feels great in the pool. So that's, of course, an option. In the pool, there's a few different positions that you can do. You could be on hands and knees. You could be in a deep squat. Most birth tubs have handles on the side, so you can grab those and do a nice deep squat. You can do what we call a runner's lunge. So you put one leg up in a lunge, like kind of an L shape, and the other leg is down on the ground. That's a really great position for catching your own baby. And of course, you can always like lay back or do a sitting up position in the birth tub as well. And you can actually also do side lying in the tub. So if you lay on your side and put your head on one side of the tub, and then you can either prop your leg up on the side, the other, like the opposite end of the tub, or you can use a pool noodle and get it like one of those big fat pool noodles, and you kind of hug it, and you can do a side lying position that way as well. Okay. So upright birth. In an upright birth position, gravity can help bring your baby down and out. There's also less risk of compressing your aorta, that large blood vessel that carries oxygenated blood from your heart to the rest of your body. So you and your baby both get better blood flow if you're using those upright positions, those lunges, doing the stairs, using your partner to like kind of slow dance while you push, using a birth sling, even that throne position where you're kind of sitting up can be really helpful. So more blood flow through the aorta leads to better oxygen supply to the baby, which leads to lower risk of abnormal fetal heart tones. So we see less dips in baby's heart rate with the Doppler when we are in upright positions, and leads to lower risk of emergency cesareans, of course, because our babies are happier. The uterus can contract more strongly and efficiently, and the fetus can get into a better position to pass through the pelvis. And it's less painful than lying on your back typically. A lot of moms report that lying on their back and pushing is actually really painful because we're pushing on that tailbone. We're creating less space when we're pushing on our back because everything is compressed. When you are pushing on like hands and knees, for example, that frees up space in that tailbone to move and kind of extend with your baby's head and body, and gives you more room in the pelvis. And evidencebasedbirth.com supports upright birth, so you can check out their articles on the evidence of and all the statistics on upright birth versus birthing on your back. And most out-of-hospital providers are great with upright birth. A lot of midwives catch babies in squats, in lunges, on toilets, in bathtubs, like wherever. Typically an out-of-hospital provider will do that. But if you have any questions and any thoughts concerning like how you think you want to birth your baby, definitely have a conversation with your provider and talk about that before the big day comes. And one question you could ask them is, how do you normally, like what positions are, have your last 5 births been born in, right? So the last 5 births that you did, what position was the mom in when the baby was born? And that can be a really good insight as to like, does your provider encourage you to find a physiological birth space and a birth position that works for you? Or are they more worried about them being able to see things or catch a baby, right? So the reason that we see moms birth on their back so often is not because it leads to better outcomes. It's not because it feels better or it's physiological or anything like that. It's because that's the easiest way for the provider to be in there, to use things like forceps and vacuums and to see what's happening. It's for the provider's benefit. It's not necessarily for the mom or the baby's benefit. There's also an old history story about how I think it might have been King Louis or someone was able to see their child be born and liked that their wife was in that position so that they could see the child. So again, not a reason to have a baby on your back if it doesn't feel good to you and if your baby doesn't like it. Okay, so let's talk about some of those tools in the birth space that I mentioned with the different position. Different things that you can use to help facilitate these different positions. The peanut or yoga ball is fantastic. We talked about it in labor. We talked about using it for resting and laying on your side with the peanut ball. You can also lay over top of it in hands and knees, and that will put a lot of stress off of your abdomen. You don't have to hold up your arms. You don't have to hold up your abdomen. So it can be really nice to lay over as well. Usually with the peanut ball, we start in labor with it up higher, so up between our thighs. And then as we move down and as your baby moves down and we start the pushing sequence, we move the peanut ball down more towards in between your ankles. And we're going to talk about the why of that more in our next slide. Next, you can see that black and white photo is the birth sling. So I personally keep a Costco hammock in my birth bag, and it works great as a birth sling. I throw both ends over a door. I make sure I have a little mount on the back so that it's not going to come through the door. And I close the door jambs shut, and then boom, you can use this for supported squats, supported standing, a lot of different positions. I think they are a really great way to utilize movement, but also get some rest for mom. So definitely take a look at those. You can find them on Amazon if your birth facility doesn't have one. A lot of birth centers will have them. You obviously wouldn't have one at home. So if you want one for that time frame, either ask your doula or you can purchase one. I think they're about like 30 or 40 bucks on Amazon. Okay, then that is the birth stool. You see the little purple seat with the handles. That's what I was talking about. That can replace the toilet and is fantastic. And the handles, you can grab the handles and kind of use those as leverage as you push your baby down. So those can be really helpful. And then your baby doesn't fall in a toilet. Okay, to be fair, I have never seen a baby actually fall into the toilet. We almost always catch them. So if that is a fear of yours, fear not. Someone will help you catch your baby. If you do end up on the toilet, that's fine. But if you don't want that, you like want a 100% chance of that not happening, the birth stool can be really helpful. And then a step stool in the space is really awesome. We can do lunges with that. We can do asymmetry. We can, if mom is sitting, we can use that to elevate feet. Also, sometimes moms like to be on the toilet, but they're shorter, like I'm 5'2". So we want to try to ease them sitting on the toilet by propping those feet up if they are a little bit on the shorter side. And then a thick yoga mat or pad. Actually, a lot of hospitals have these in their cabinet and not a lot of people use them. You'll also see them at birth centers. And then of course you can have a yoga mat at home, but you take those out and they're great for protecting the knees and the wrists if you want to do hands and knees or do some different positions on the floor. Utilize the floor, man. That's a great place to do those things. Sometimes doing hands and knees and lunging and things like that on the bed can be kind of hard because of the soft and squishiness of it. So definitely get down on the floor, crawl on the floor. Those are great places to be to have a baby. Okay, so we talked about that peanut ball, and this is why we're going to move it from the top in between our thighs down in between our ankles, knees in, calves out. So this is from Mama Stay Fit. I definitely recommend everybody follow them on Instagram. They are amazing, and they go through the mechanics of birth a lot, and like the physical skeleton and how we can aid in the process of childbirth by doing different positions. So they kind of coined this knees in, calves out. As you can see, in the red square, that external rotation square, you would think that creating space between your knees would help you, right? But in actuality, that makes the bottom of your pelvis smaller. Okay, so when you rotate your knees out, your hips are doing more of this kind of a motion. And you can see that with the red arrows. So that if we open our knees really wide, which is what we have seen in movies and TV and what everybody tells you, because you want to make space for the baby, actually we're creating kind of a pinch point at the bottom of our pelvis for our baby. Instead, we want to bring our knees in and our ankles out and create more space at the bottom of our pelvis so that our baby has more room to rotate. So this is when our baby is really nice and low and we're getting close to like seeing head, things like that. Try and do those positions. As you can see from top to bottom, you can be in hands and knees and put your knees in, your ankles out. You can do this side lying. We can put a peanut ball in between your ankles. That really helps the knees come together. Or even if you're on your back, you can still kind of rotate your legs so that your feet are out and your knees are in, and that will create more space for you. So one thing I recommend to all of my doula clients is this podcast episode by Wapio, Rethinking the Pushing Stage. It's on the Birthful podcast, and you can find that on Apple Podcasts, Spotify, anywhere you can find podcasts. You can go to birthful.com, BIRTHFUL, and I'll have it linked in the show notes or in your email as well. But this is an amazing podcast episode thinking about the pushing stage and how we've kind of decided that we want to try to control it and how you really can't, and more of listening to the mother, listening to the body, listening to the baby. So you can also go to lamatrona.com. That's where Wapio's website is as well. And she has a great article on the holistic stages of birth. I give it to every doula client. And this is a really great way to reframe the way that we think about the stages of labor and the pushing stage especially. So take a look at that, listen to it, see what you think, see if it changes your perspective on pushing. All right, water birth. So let's talk about water birth and why it is safe. So babies are not going to take their first breath until their face and nose feel the cool air. Remember also that your baby, their lungs are full of that amniotic fluid, which is more dense than water. So when your baby comes out and is born into the water, that amniotic fluid inside is going to help make sure that we don't have water coming in because it's already got the denser fluid in there instead, which is totally normal. So your baby can come out of the water and they won't feel that breathe reflex until their face hits air. To them, it's like they're at an extension of the uterus. They're still in that amniotic fluid, so they will come out. Now, this also means that you can have a baby out of water, you can have a baby in water. We can't have kind of in between. So you need to make sure that if you are in the tub, that the water is deep enough so that mom can have her entire bum underneath the water and have the baby completely in the water. What we don't want to do is kind of stand up and be half in the water, half out. We don't want to dunk our baby after their head is out. We don't want to like dunk them back into the water. And we don't want a baby to come out and then fall into the water. That's when they can aspirate the water and take that water in. So we want to make sure we're either all the way in or we're out, not kind of in the middle, which can be kind of hard, especially if we have any kind of emergency situations like dystocias. Typically we get mom out of the water and to do things on dry land so that we don't have the risk of baby falling into the water. Tub temperature needs to be somewhere between 98 and 100 degrees. We want to make sure it's not too hot, and we want to make sure it's not too cold for baby. And the placenta can be born in the water, or you can get out and birth your placenta too. Just kind of depends on your preference. I will give you a little pro tip that having the placenta in the water makes for an easier cleanup postpartum for your birth team, but you do whatever you want. Sometimes moms like to get out and sit on the birth stool or sit on the toilet to birth the placenta. You can do either one, or you can stay in the water. Totally up to you. Can be an amazing coping techniques for moms and partners you can get into. I promise it's really not that messy until baby and placenta come out. So a lot of times it's helpful if a partner throws on a pair of swim trunks or swimsuit or whatever you've got going on, and you kind of sit behind mom and you can help like support her. You can lean back and hold on to your partner, or you could face to face, and you can kind of pull on their arms to help with get some leverage. And then if you guys are planning on both of you catching your baby or a partner catching your baby, they can help guide your baby out in the water as well. So I always tell every partner to bring a bathing suit with them to the birth center if you're going to have a birth center birth or have one at home. If you have a birth team there, midwife and doulas, please don't go in naked. Please wear a swimsuit. That's all I'll say. And then your team will do all the cleanup of a water birth. Your midwifery team and assistants should be the ones draining the tub and getting the liner and cleaning it all up. As you can see there, that picture is the blow up tub. So that is birth pool in a box. That's a lot of what the midwives will rent out. That's usually the brand that they'll rent out for home birth. And it's really not that big of a deal. It looks more intimidating to get set up than you would think. So you just want to make sure though, once you turn 37 weeks, typically if you're having a home birth, your midwife will drop it off for you in a box, a big tote. And you do want to make sure you've looked at it before it's the big day. Don't be like me and not get your birth tub because you didn't blow it up and then you had a precipitous labor. That's not a good time. So what you want to do is make sure that it's either halfway blown up or blown up before the big day, and store it in a space where it's not going to get messed with if you have an extra room or a basement or whatever. But make sure that it can get through the doorways if you are going to blow it up beforehand. But it comes with a little air pump. Most sets, make sure that you ask your midwife their specifics, but typically it comes with an air pump. So you pump it up and it takes a little while to blow up. Honestly, this is a big tub and it's very tall. So it does take about a half an hour or so just to blow it up. And then it will come with a liner, a clear plastic liner. So you want to make sure that the liner is inside before you put water in. Don't put water in before you put the liner in. That's very important. So you put the liner over the birth tub. Then you take a hose. Typically, your birth tub will come with a clean hose that stays with the birth tub. We will use 2 hoses for the birth tub. So you want to make sure that you use the clean hose to fill it. You do not use the clean hose to empty the tub. So you fill it. You can either hook it up to a shower head or a kitchen sink, or you can put it directly to a water line. You do want to make sure you have a rubber adapter on the hose. Look in the box, make sure that it comes with one of those, or if your tub does not, you might have to go to like Lowe's or something and pick one up. But you want to make sure you have that rubber adapter so that we can put it on different faucets just in case, and make sure that the connection is really good before it's the day of birth. And then you also want to make sure that you've got enough kind of hot water that we can fill the tub up and still keep a nice hot water. So everybody's hot water heater will be different. So make sure you take a look at that and maybe turn it up a little bit before the day of birth. And then if we need to, we can always re-warm it with big pots of boiling water on the stove, and your birth team will help you facilitate that as well. And then in the cleanup, there's a pump that comes in the kit as well. So we use the dirty hose. Typically, you're responsible for purchasing that. We use the dirty hose. We put it on the pump. We put it in the water. We pump it out either into the toilet or the drain, or we pump it out the window. Totally up to you, whatever you want to do with it. We throw away the liner. We wipe down the tub, and then your midwife will pick it up in a couple days or wherever you rent it from, or maybe you have to take it at an appointment or something like that. But make sure you talk to your birth team about the logistics of the birth tub if that's something that you want. And then at birth centers, typically it's a built-in tub, so you don't worry about any of that. And the people that work at the birth center will take care of those things for you. All right, let's talk about protecting the perineum. So, evidence actually shows us that the best way to protect the perineum, remember it's that space between the bottom of the vagina and the anus. That's that tissue that's typically where we see tearing in birth. And the best way to protect it is to leave it alone. So no hands in it, no stretching it, no doing anything like that. And especially if you're in a water birth, all that nice warm water is going to be helpful in stretching. What we can do is if you are on dry land and you're not birthing in the water, if you want something to help or you feel like you need some pressure on it, a lot like if you got a paper cut, you would kind of grab your thumb. If you feel like you would like some pressure on that, you can use a warm compress. So either your partner or your midwife can facilitate that. They can just take a warm washcloth, like dip it in warm water, and then kind of hold it on the perineum, or you can do it yourself as well to kind of feel that area. You can also use lubrication like olive oil or mineral oil to kind of help get things nice and stretched out. However, we don't really use that quite a lot in the home births that I assist with because typically there's lots of juices already and we don't need the lubrication. But if we are crowning for quite a while, sometimes it can be helpful to use that. And then the number one way to protect your perineum is with physiological pushing. So instead of that purple pushing, instead of being told push as hard as you can after the head has emerged, instead of doing those things, listening to your body, waiting for that rotation, waiting for your baby to come out. We're going to talk about times where maybe that's not the case later in the class, but for all intensive purposes, with a normal physiological birth where we don't have any emergencies, physiological pushing is best. You can also use horse lips breathing or panting. So sometimes it's really helpful for moms because when you have the pressure of crowning, a lot of times moms just want to like blow a baby out. They're like, I'm ready for this to be over. And you'll just instinctually just start bearing down as hard as you can. If you have the capacity to do horse lips breathing, that can be really helpful to slow it down. Remember, we want a nice slow stretch of your baby's head through the perineum, through the vaginal canal so that we can stretch all of that tissue, stretch that perineum. So you can do kind of or like kind of breathing during that crowning phase of pushing. Doesn't always work out. Sometimes you just push out a baby and that's okay too. But if you can do those small little pushes at the end, that can be really helpful. And then of course, mom or the birthing person can support their own perineum with touch. So you can reach down and you can kind of hold the tissue yourself so that you can kind of feel what's going on. That's 100% okay. Sometimes it's just like too hard for you to like think about that and facilitate that. Other women will like instinctively reach down and protect their perineum themselves. So you do whatever feels good in the moment. All right, so now we're having a baby. Let's talk about the third stage of labor and the immediate postpartum. The birth pause. So what's the birth pause? Well, practically speaking, instead of delivering your baby directly to your chest, your midwife will simply guide your baby down where he or she is born. They'll land gently on soft pads in a warm pool of amniotic fluid. They'll stretch out their arms and expand their lungs for those first sweet gulps of air. You'll likely take a breath yourself and gather yourself together after the huge effort of birth. You will then probably turn your full attention to this newly born child lying in front of you. You'll be the one to welcome your child as you touch their hands, arms, legs, belly, kind of look your baby over. And then when you're ready, you will be the one to wrap your hands around their torso and bring your baby up to your chest, claiming your baby. The moment of birth itself will be held by this pause, a pause in which you and your child first find each other on the other side of birth. So the birth pause can be this amazing experience. I kind of frame it around like if you were to work and train for a marathon, an ultra marathon, an Ironman, and it's race day and you go through the race and you cross the finish line, immediately after crossing the finish line, then throwing you a baby. that's a lot what it's like. That's what it's like. Typically when we see birth in this day and age is people just like skin to skin and they throw a baby right onto your chest. Well, that can be kind of jarring and maybe not as instinctual as the mom would have normally done. So what you can do is you can talk to your team about a birth pause. This is a little harder if you are in the water having a water birth, but if you're on land, especially, this is something that can be a really great idea. So that is where, just like I talked about, after the baby is born, we just gently place the baby near you, either on the bed or on wherever we are on the floor, or like in this picture here, dad is the one holding up baby and kind of holding the baby while mom takes a few seconds to get her bearings. So literally it's typically like less than a minute that we see a mom, and don't worry, everyone is still checking on you, making sure you're okay, making sure baby's okay. Midwife is still doing APGAR scores and making sure your baby looks good. They're just not like, messing with your baby a ton, but we're still making sure everything is fine. And you take a few deep breaths and kind of come back into your body before you look down and look at your baby and then pick your baby up and take them skin to skin with instinct. So it can be just a lot more gentle way to transition from labor and birth to having your baby earthside. So a lot of times we'll see in movies and videos, like the baby comes out and the whole team just descends on them and like throws the baby on mom's chest and just starts stimulating that baby as hard as they can. We don't necessarily need to do that. It can be a much more gentle process. Of course, if baby is compromised or that we're having some kind of issues with baby, then yes, your team will step in and do a little bit more stimulation for you. But for the most part, we want mom to claim their baby. We want mom to rub their baby and bring them into their body. So this is something that I honestly don't see a ton of because we just get so rushed in the end stage of birth and everybody's got adrenaline running and pumping and we're just excited to have a nice healthy baby earthside. But it's definitely something that you can talk to your provider about if you're interested in it at all. All right, so what's happening immediately after birth? Your baby's going to take their first breath. And they're going to go skin to skin with you once you claim your baby. And then your midwife is going to assess the baby while they are skin to skin with you. So they're going to get those APGAR scores that we talked about. That measures their heart rate, their respiration, so their breathing, their muscle tone, baby's color, and reflex. So, kind of how their movement is. We want to see a movement baby. And we get those scores at 1 minute and 5 minutes for babies. They are out of 10. So your baby gets can get possibly up to 2 points per thing. So 2 for heart rate, 2 for respirations, 2 for muscle tone, 2 for color, 2 for reflex. And that equals 10. I will say nobody gets a 10. Almost nobody gets a 10. It's very unlikely that you're getting 10s, but like 8s and 9s are great. We just want to make sure, because typically, all babies come out a little funky colored and maybe a little, have a little bit of a time, takes them a little bit to like get those respirations and get that cry, and that's okay. But so that's what your team will be doing. So you might see your midwife with their stethoscope on, just checking baby's heart rate, or they might be holding onto the cord and feeling baby's pulse through the cord, just making sure that everybody's looking good, making sure you're looking good. And then pause and rejoice because you did it. So we're going to take a minute, make sure everybody's looking all right, making sure your bleeding is good too, which we'll go into. And then you get a second to just kind of breathe and look at your baby. So what's happening to your hormones immediately after birth? The hormonal shift immediately following birth is considered to be the biggest, largest sudden hormone change to occur in the human life cycle ever. So estrogen and progesterone, those chief pregnancy hormones, are going to do a huge decrease, drop dramatically. So you might have a roller coaster of emotions or trembling, a lot like in transition. Remember how you would get kind of shaky in transition? You might also get that immediately postpartum, to where you're not necessarily cold, but you're kind of shaking because of all of the hormone release. Your prolactin, which is your your milk producing hormone, has a steady increase that initiates your milk production, low energy, and kind of slows your metabolism down. And you're also getting a nice big boost of oxytocin and endorphins after the birth as well, for bonding and for pain relief too. All right, the birth of the placenta. So let's talk about delayed cord clamping. Wait for white. So this is a topic that you'll need to talk to your provider about, and you'll need to talk to them about it in depth. So there is no standard of delayed cord clamping. That's just a term that we use, but every provider will do it differently. So some providers will say, oh yeah, I do delayed cord clamping, but it's only 1 minute. Or some will say, I do delayed cord clamping and it's 5 minutes or 10 minutes or whatever. So when you talk to your provider about what their delayed cord clamping is, you should say something more like, instead of do you do delayed cord clamping, you should say, how long do you wait until you clamp the cord? And they should give you an answer. And really the correct answer would be that they wait for white. So they wait until your baby has all of their cord blood back into their body, right? That is your baby's blood. We want to make sure that they get all of that nice blood, cord blood back into them. Your baby is not going to like send it back to the placenta or whatever. So waiting for white is good. You could do that. Sometimes it's like 7 minutes for people. Sometimes it's 10 minutes for people, 15 minutes, either way. And then you can clamp the cord and cut it. So you'll probably feel cramping, like early labor contractions, and you're going to be thinking to yourself, what? I thought these were done. I have my baby. Why am I still cramping and contracting? Well, remember, we still have to get that, your uterus has to get that placenta out. So your placenta will detach from the uterine wall, and then your uterus will clamp down to clamp itself down and to get that placenta out. So it will probably feel like little contractions. You might feel those for a few days after the birth as well. Typically it happens every time your baby breastfeeds. That's really normal and really good. It's annoying, but we do want to see it. As your baby releases that oxytocin while they breastfeed, that helps your uterus contract and helps it bring it down to size, helps stop the bleeding, all of those things. So they are necessary, those contractions. You might need to help push with the placenta. The silver lining of this is that there's no bones, so it's like a big jellyfish coming out of you. It actually, typically people will say that you feel a lot of relief after the placenta comes out. But it is possible that you'll need to do some work to help push that placenta out, just like you pushed out your baby. And that can be really jarring for some people and kind of hard to figure out because all of your muscles and tissues have just been stretched so far to accommodate your baby that sometimes it can be hard to like get the hang of getting that out as well. Like I said, breastfeeding can help encourage the placenta. And then after your placenta comes out, your midwife or provider will examine the placenta to make sure that it's intact. This is really important to make sure that all of the pieces of the placenta fit together and we don't have anything left inside of you. If you did have a piece of placenta left inside of you, that's called a retained placenta, and that can cause problems for us. That can cause bleeding, it can cause infection, it can be kind of bad later on down the road. So we want to make sure that all the placenta comes out when the placenta comes. And your midwife will monitor your bleeding after the placenta, and you get that fabulous fundal massage. So fundal massage is when the midwife or their assistant will take both of their hands and kind of rub the top of your uterus to make sure that it's firm. They'll hold the bottom with one hand. They'll rub the top of the uterus with the other hand to make sure that it's nice and firm and coming down. We want to make sure we don't have what's called a boggy uterus. So we want to make sure that your uterus is getting tight and clamping down because that's what's going to help stop any bleeding that you might have. So they'll do that every, more in the beginning, and then it'll space out. So we'll do it quite a bit right in the immediate postpartum, and then about every half an hour or so before you're discharged. It shouldn't be called massage because it's not a very fun massage. All right, let's talk about the golden hour. So skin to skin with baby as much as possible. That can be mom, that can also be dad too, or partner. If mom needs a second to like get up and go to the bathroom or whatever, adjust themselves. Or if for some reason there is a lot of bleeding that needs to be stopped immediately, then we would put dad or partner skin to skin with the baby. So they're still getting all that nice skin to skin time, but mom can be focused on. So like I said, you'll be experiencing shaking from the hormones. You also might be feeling lots of emotion. You're like, the hormones are going crazy and you are happy, you are sad, you're excited, you're just kind of all over the place. You're getting that rush of adrenaline. Bonding with baby will happen in that first golden hour. We should make sure that mom is eating and drinking if possible. Get her like a good meal, okay? Some iron-rich food. to make sure that they're getting nice and fed. So that means that, like, if it's the middle of the night and we can't go get food, make sure you've planned for that. So maybe that's bringing a casserole to the birth center with you that you can warm up during the pushing stage so it's ready to go when mom has the baby. Or maybe it's at home, making sure that there's some freezer meals or something like that that we can put out quick that's nourishing and help in that postpartum time. Mom goes up to the bathroom if able. So that's when the baby can go skin to skin with the partner, like we talked about. So going up and doing that first restroom break. And at some point towards the end of the golden hour, the midwife will evaluate the perineum, depending on what's happening. So if there is a lot of bleeding and it's believed that the bleeding is coming from a tear, then that's a situation where the midwife will address that pretty immediately after the birth and make sure that bleeding is regulated and that mom's okay. If you don't have a tear, or if the tear that you do have is not like bleeding, then the midwife can wait to do any kind of repairs, if there is a repair to be done, more towards the end of that golden hour. We want to try not to go too far, into the postpartum, hours after the postpartum, to do your repair, because we do want you to get that good physiological sleep around hour 4. So typically we'll do repairs between hour 2 and hour 3. And if you're at home or at the birth center, you will be, if you do need a repair, you'll be numbed. So they'll use lidocaine. Typically, talk to your provider about what they specifically use. But typically they'll use lidocaine injections, and they'll inject that with a needle into the perineum. It's stingy and it stinks, but it numbs you all up so that then they can do any kind of stitching repair that they would need to do. If you're at a birth center that has nitrous oxide, you can also use the nitrous during your repair, even if you haven't used it during your birth. If you want to use that during the repair, just like that laughing gas like you get at the dentist, that can be really helpful to help you kind of relax and get through the repair time as well. Highly recommend for postpartum. Okay, so what is your birth team doing? So your team will stay with you between 2 to 4 hours at a home birth. So usually you'll have the midwife and you'll have an assistant at home, and both of those people will stay with between 2 to 4 hours. And then typically the midwife and the assistant will leave at the same time. At the birth center, your midwife will stay about that 2-hour time frame, make sure that you've got any repairs, make sure that you're good to go. And then an RN will be present for the duration of your stay. So at the birth center, someone is always at the birth center, and typically those are nurses that are on staff, will be there to help you until you go home or until that time frame is up. So your midwife is monitoring vitals on mom and baby, completing any perineal repairs, charting, administering any necessary medications that you might need, and doing the newborn exam as well. And the newborn exam usually happens again between that 2 to 3 hour mark, is when they do the newborn exam after they've had a nice little feed or you've latched baby and you're feeling ready for the next step and had your golden hour. The assistant or the RN will be assisting the midwife, helping mom get settled. So we help you get up to the bathroom. We help you get on the Depends afterwards, or if you want to get dressed, we help you get dressed, things like that, helping you clean up. So typically we don't throw you in the shower right after the birth, because a lot has just happened. You might have lost a good amount of blood. So we don't necessarily want to throw you in a hot shower right afterwards. You could be really dizzy. It could be kind of hard for you to stand for a little bit. So typically we just use a warm washcloth and we wash you up really good. And then we would encourage you to do a shower or a bath maybe in a few hours after you have a nice good sleep and had a good meal, or maybe even the next day is totally fine. And then the assistant will also be emptying the birth pool, cleaning up the space, and then gathering the midwife's tools, cleaning the midwife's tools, doing all of those things as well, and possibly helping with charting as well. All right, so let's take a break, stand up, stretch. It's a lot of information. Go get a snack, and I'll see you back for variations of normal and emergencies. Okay, I hope everybody got a really good break, did some stretches. Maybe you did your 3 sisters during the break time. That would be fantastic. And let's get into variations of normal and emergencies. Okay, so let's talk about some variations of normal that can happen, especially in out-of-hospital birth. Obviously, anything before 36 weeks or 37 weeks, depending on your provider, that would be something that would be a transfer of care, and you would be then switched over to either an OBGYN or a midwife in a hospital setting. So we're going to go over some things that can happen during that window of when you would be cleared for out of hospital birth. So that's between 37 and 42 weeks. So before labor, there's the possibility of preeclampsia. So preeclampsia is high blood pressure in the pregnancy time frame. And you may also have the presence of protein in your urine and consistent high blood pressure or swelling, edema, and dizziness. So those all can be symptoms of preeclampsia. The blood pressure is typically 140/90 or higher, and the protein in your urine are really good indicators. So if you're showing those signs, your midwife will monitor you for a while, but if it's something that can't be resolved or your blood pressure increases, you would be switched to in-hospital or offered an induction of labor. The only way to fix preeclampsia is to have a baby, and preeclampsia can cause seizures for mom. So it is something that we take very seriously, and it would be a reason to transfer care if it can't be under control. Gestational diabetes sometimes can be managed with diet, but may also require insulin. Your provider will monitor your sugar levels closely to make sure you're safe for an out-of-hospital birth. Your baby will most likely have their blood sugar drawn after birth to make sure that they're adjusting well as well. So the blood draw for baby usually happens right after birth. So gestational diabetes, it just kind of depends on how severe the case is for you and how it's being managed, whether or not you would be cleared for an out-of-hospital birth. So that's something that you would want to talk to your care provider about. There is a book called Real Food for Gestational Diabetes by Lily Nichols. She also has a book called Real Food for Pregnancy, and I highly, highly recommend that you check those out, especially if this is your second, third baby and you've had gestational diabetes in the past, or if you have diabetes outside of being pregnant. I would say look at those books, follow that diet, and it can be really helpful in managing that. Cholestasis is a liver condition that usually occurs late in pregnancy. The signs are intense itching all over without a rash. So you'll have like your hands and your feet feel really, really itchy, like you can't sleep. They're so itchy. Nausea, loss of appetite, and yellowing of the skin or eyes are also symptoms. And this condition does increase the risk of preterm labor and stillbirth and should be closely monitored. And your provider may require an induction of labor. So a lot like preeclampsia, the only way to fix cholestasis is to have a baby. So these are all, these three issues might be a reason for an induction. It just depends on the severity of your diagnosis. So it's definitely something to talk to your provider about, whether that would be like if you're 37 weeks or on, does that look like a induction of labor at home, trying like quote unquote natural induction methods, or does that look like you going to the hospital and doing a medical induction? Premature labor. So anything that happens before 36 weeks, like we talked about, that will be an automatic transfer. We want to make sure that your baby's lungs are fully developed and ready for breathing on the outside world. And obviously we don't have a NICU at home or at the birth center. So if we go into labor before 36 weeks, you'll be transferred out of care to a hospital setting. Premature rupture of membranes. So this is if your water breaks before labor begins. Remember we talked about in the last class about what happens if your water breaks beforehand. This can look very different for very different people and very different providers. So it's really important that you ask your provider about what their timeline is for when your water breaks before labor. And if you would be transferred out of care at like 24 hours, 48 hours, 72 hours, what does that look like for them? When do they transfer you to do a medical induction in hospital? And what kind of things do they do if your water breaks and there's truly no labor? So there's also like very different variations of that. If your water breaks and you're having contractions, that's different than if your water breaks and there's absolutely no contractions for like 48 hours. So that's something to definitely ask your provider about how they handle. Placental abruption. So this is when your placenta detaches from the uterine wall, and this is a true emergency. Usually we'll see bright red bleeding immediately, but not always. So it's something that you want to make sure you're doing your kick counts with baby, making sure that baby is moving daily, check in with your baby, check in with your body. A placental abruption is that true emergency. We're going to the emergency room right away. And this can happen before labor. This can happen during labor. This can happen, kind of randomly. Persistent breech presentation. So we talked about in class 1 about breech presentation. Now, for some providers, it is an option to have a baby out of hospital. For others, they would transfer care for you to go to have a baby in the hospital setting. And that might look like a vaginal breech in hospital, if you can find a provider that does that, or it could mean a cesarean section birth. Cord prolapse. So this is when the umbilical cord comes out ahead of the presenting part of the baby. So if your baby is head down and a cord comes out and then the baby's head is above it, and it's like you've got kind of a cord dangling close to or down through the vagina, that is a cord prolapse, and that is also an immediate emergency. So the baby's pressure of head can pinch off that cord. Remember how we talked about that Wharton's jelly and how great that the cord is at protecting itself? Well, there are limits to that. So if we have a baby whose head is compressed onto the umbilical cord, then it will pinch off the umbilical cord. So that is an absolute emergency as well. And that is something that would be that you would immediately transfer care to the hospital. Things that increase your risk of cord prolapse is having your water broken before, anytime you have your water broken, it's an increased risk of cord prolapse, but especially if you're in that first stage of labor, so anywhere between 1 and 5 centimeters dilated, it's a more increased risk as well. Okay, so some things that could happen during labor. Again, I don't tell you any of these things to scare you, but I do tell you these things so that you can be informed if one of these things, or in the unlikely event they were to happen. I want to make sure that you have some information on these things. So during labor, non-reassuring fetal heart tones. Anywhere between 110 and 160 beats per minute is normal for fetal heart tones. Your midwife, if you're at home or at the birth center, will probably be doing the Doppler and doing intermittent monitoring at different times. And it's important that they're kind of checking on where your baby's baseline is, if there's any variation. All of those things can be a factor into how we assess how your baby is doing. If our baby drops off completely, but we're not in that pushing crowning phase, then usually that would be a non-reassuring fetal heart tone. It possibly could mean that your baby is moving lower into the birth canal. Sometimes when they're getting squeezed in the birth canal and we're getting ready to actually have a baby, their heart rate does slow down because they're getting that good squeeze, and that's normal. And then other times it's not. So your midwife is trained in assessing that and making sure that we're still looking good. It's possible that they would transfer you if baby doesn't continue to recover. Sometimes it means that something's going on with the cord, or something's going on with baby's positioning, or something that we don't clearly know. So that can be a reason that you are transferred as well. Fetal malposition. So this can look different for everybody. If we have a baby that all of a sudden presents butt first and we thought that they were head first, depending on your provider, that could mean an emergency transfer for you. Just kind of depends. So you would want to make sure that any provider that you hire would feel comfortable if a butt came first before head and wouldn't panic. Also kind of depends on what the rules are at that birth center, lots of different factors in that as well. If we have a baby that kind of turns transverse, obviously we're not going to be able to get out of transverse baby. We'll learn that in class 1. So that would be a cesarean section. And then sometimes we just have a baby that's a little funky. So maybe they have hands up here, maybe they aren't tucking their head, or maybe they're asynclitic, which is when they turn their head to the side and they're coming towards your hip. Fetal malposition can lead to longer, harder labors. So sometimes that means that you would want to transfer just for therapeutic rest, like getting an epidural. Sometimes it means that we just have a longer labor and we wait it out until baby gets into a better position. Elevated maternal blood pressure. So again, that preeclampsia can actually happen in labor as well. So that's one of the reasons that your provider would be checking your blood pressure every 4 hours. They do a full set of vitals during labor. So they want to make sure that blood pressure is still looking good on mama. And then prolonged pushing stage. So this is like 4 hours plus is what I would maybe call a prolonged pushing stage. So at that point, we might be starting to look at like maternal exhaustion. So there's a possibility that you would want to transfer for, again, therapeutic rest. Arrest of labor is sometimes a reason that people would transfer as well. This is just if like you're in the middle of labor and things just kind of stall out and don't start up again. There's other things that you can try as well, such as like castor oil, different acupressure points, different positioning, just getting a nap in. So it would really have to like stall for quite a long time for you to necessarily be like wrist out. And then shoulder dystocia. So this, like we had talked about before, remember how we talked about the head being born? If the head is born and we don't have a body after about 4 minutes, that is what we would categorize as a dystocia of some sort. So that's a dystocia means that the body of the baby is getting stuck somewhere. Shoulder dystocia is we're getting stuck right here. So there are different signs that we as providers would see that would indicate to us that a dystocia might be happening. This is, again, a true emergency. We need to have a baby and we need to get the baby out within we like to have a baby out within 3 minutes. But after that, we would be doing different position changes, like quick position changes to try and open that pelvis and get baby out. Your provider might also kind of reach in and help guide the baby's shoulders out as we do those positions. So if for some reason your baby's head comes out and we don't have shoulders after 3 minutes, we would probably stand up first, and then we would do what we call a runner's lunge, a deep runner's lunge. So you would have your foot up by your head, just like if you were lunging and stretching out your legs, you would have that, but it'd be very deep. And then we would help you, if we still don't have a baby after that, we would help you go onto your back, and we would bring legs like knees to ears, and your provider might help guide baby out, and then we would kind of switch through those things. It's possible that that would be an emergency transfer as well. Typically with shoulder dystocia, we have babies that have a harder time coming around and are more likely to need resuscitation. So just know that that is a possibility after the dystocia happens as well. So after labor, resuscitation of the newborn, like I just talked about with shoulder dystocia, can be an emergency. So some resuscitations can be handled at home and we just stay there and, you give baby a few puffs of air with our bag and mask and everything is fine. So resuscitations can happen in a few different scenarios. If you have a really, really fast labor, sometimes that baby didn't get enough squeezing to get that amniotic fluid out and clear their lungs. So sometimes they just need a little bit of help clearing that airway. And we do that with those positive pressure ventilation breaths with the bag and mask. Sometimes with really, really long labors, the babies have been in the birth canal for quite a long time. Sometimes they take a little bit longer. Dystocias, different things can increase your risk of having a resuscitation. So your provider will bring all of the tools necessary for a resuscitation, and we put them on. You'll see a cookie tray on your list of things that you need to have in your kit. So you want to have a cookie tray, and that's where we put all of the tools that we would need in the event of a resuscitation. And we keep those with you so that that tray is with us anytime you move rooms or areas. We keep that tray right by you as the assistance to make sure that we have all those tools should we need to resuscitate any newborn. So like I said, most resuscitations can happen right there. Sometimes some we can even do on mom's chest, depending on how we have baby positioned. It's a little harder with like a water birth, but usually we can do them on mom, give baby a few puffs of air, and typically we'll see baby start to come around after about 5 puffs of air or so. Other true emergencies, if we don't have a baby that comes around, we'll continue doing positive pressure ventilation. If baby doesn't have a heart rate above 60, then we'll do chest compressions as well on baby. And at that point, if ever we're doing chest compressions, we're also calling 911 to come and do a transfer for the newborn. In the event of a true emergency or resuscitation, it'll be important for the partner to kind of help out a little bit. So if you just have two people, if you have a midwife and an assistant there and they're working on the baby or they're working on mom, a partner or anyone else present at the labor, doula, whatever, may be responsible for calling 911 and getting that transfer going. So just know that you need to talk through those things, talk through those scenarios with your provider and see how they handle things. Same thing goes for maternal postpartum hemorrhage. So if we have a mom that's bleeding a lot, it's possible that we would start an IV, give her Pitocin, give her Pitocin, give her Cytotec to try and stop the hemorrhaging. And it's possible that we would need to do an immediate transfer as well. Anything after 500 units of blood, we're nervous about. Anything over 1,000 is definitely a hemorrhage. So retained placenta, again, that's when we talked about how the placenta stays up in the uterus and doesn't come out. If that happens, and I mean, if it's been like an hour or more and we still don't have a placenta, typically the placentas are born within like 15 to 30 minutes. If we're past an hour, then we might start thinking about ways that we can either get the placenta out or transfer of care to get the placenta out. Now, sometimes that looks like once you transfer, manually extracting the placenta. So a provider would go in through the vagina and take the placenta out manually. Sometimes that's also like a D&C as well. So those are some variations of normal that can happen in the out of hospital setting. And just know that your team, make sure that you vet your team, you interview your team, and that everybody is fully equipped and trained to make sure that you are safe. Ask your provider to like, hey, can you show me what you bring to births? Can you show me through your birth bags? Can you tell me what things are used for? To make you feel comfortable that you have the best care possible in this out of hospital setting. Okay. Fetal monitoring. So there's a few different types of fetal monitoring. Intermittent, as you can see on the left-hand side, that black and white photo, that is most likely what you're going to have from a provider in the home or birth center in birth center setting. So that's just the little Doppler, and they put it up to your belly. They listen for a few minutes. Maybe they listen through a contraction. Maybe they listen right after a contraction to just kind of get a baseline on baby's tones. And then they do it, it depends. So at the beginning of labor, we do it, I think every 30 minutes. And then as you get closer to pushing and having a baby, it goes to like 15 minutes. And then it goes to every other contraction as you are pushing and we're about to have a baby. So just keeping an eye on them, but still giving you full freedom of movement and not hindering in any way. A lot of times in the out of hospital setting, you move, you sway, you do what you need to, and the midwife will work around you. You don't need to work around the midwife. They can do this in a lot of different positions. They can do this in, those are waterproof, so they can put, not the whole thing. The wand is waterproof. They don't want the big box that like has the speaker in it to go in the water, but they can listen in the water and you can have full range freedom of movement. There's also something called continuous fetal monitoring. So this is what we typically see at the hospital. And actually evidence-based care shows us that continuous fetal monitoring does not increase our positive outcomes in birth. So we do it because we think we feel safe, but then it also leads to a lot of unnecessary interventions. So continuous fetal monitoring, like you'll see in this photo, typically you've got two cookie-sized monitors, and those are the black and the gray bands are belts that they use to keep the cookie monitors in place. So in the hospital, you can have wireless or wired monitors, just kind of depends on what's charged at any given moment. Sometimes the wireless ones need charged. They can also go in water, they can go in the shower, they can go in the bath. If you're on the wireless, you can kind of move around. If you're on the wired, then you're tethered to that. If you can see the wood box in that photo, that's where all the stats come out of it. And you're kind of tethered to that area. So you can stand, but you have to stand near that box. Or typically they'll have moms like lay in bed. If for some reason you have an epidural or you're having like a medical induction, you've got IVs going on, you've got Pitocin going on, then they would do continuous fetal monitoring on you. And you would keep those on the entire time. So there's also Internal fetal monitor is an option as well that might be presented in the hospital setting if for some reason we've transferred care. So this is comprised of 2 pressure catheters, and one of those goes onto your baby's scalp. So there's a little wire screw at the top of this electrode, and it actually screws into your baby's skin on the top of your scalp. And then there's another pressure catheter in there that tracks the intensity of your contractions. So this internal fetal monitor is only used if for some reason they can't get a good reading on baby with the external monitors. You might also be presented with this option. Just know that that does go into baby's scalp. Okay. So what tools is your team going to have? So your midwife in the birth center or at home will have a stethoscope, blood pressure cuff, thermometer, Doppler. Those are all for taking fetal heart tones and for doing all of the vitals, your vital signs every 4 hours. And then they're also going to have what's called an infant ambu bag. So if you look at the photo, that blue kind of bulb area with the mask on it, that's what they use to give babies breaths with. That helps us determine how much pressure we're giving baby and make sure that we're giving them nice, even breath. So that's what the infant ambu bag is called. And if we were to use it at a birth, we replace the parts and we replace the whole bag. So you only get an infant ambu bag that is used specifically for your baby. LMA device is something that we would use if we can't get the breath into baby and we can't get it into their lungs. It's possible that we would use this device, which is kind of like a tube that goes down through your baby's throat and helps deliver that oxygen to baby. We use those very rarely, but I have seen them used. A DeLee is like a suction. It reminds me actually a lot of the Nose Frida booger sucker. So it's a device where the midwife would put it down baby's throat and suck out any fluid that they couldn't get out with like a bulb syringe, which again, normally we don't bulb syringe. Normally we don't DeLee. This isn't a baby that's like compromised that we can't clear. Sometimes we'll do what's called postural drainage for a baby. That's usually our first step, is postural drainage. So we'll take baby and we'll kind of position them like this. You can see in the video, and kind of hold their head. And usually this is enough to drain any fluid that baby might be holding on to that they're not getting out before that first big breath. But if this does not work, then we go to the bulb syringe, then we go to the DeLee. So just know it's the third line. Pulse oximeter. So that's a device that just goes on your baby's hand. It's like a little, what am I thinking of? Like rubber, like little rubber device that goes onto baby's hand that just measures how much oxygen is in their blood and making sure that they're getting really good oxygenated blood. It doesn't hurt baby. It just shows us those numbers. It just sits right there on their hand. Pitocin comes in the midwife bag. We don't use Pitocin during labor. We don't use it to augment your labor at all. It's strictly there that if mom were to be bleeding more than normal and need a little bit of Pitocin to help clamp down that uterus, we keep it for the postpartum time. Same thing with Cytotec. So that is a little pill that we bring as well that the midwife can administer either orally, vaginally, rectally to help with bleeding. So typically if we do have a lot of bleeding and we're looking like it's closer to a hemorrhage, we would start with Pitocin and then we would do a dose of Cytotec. Then we might do another dose of Pitocin and another dose of Cytotec, and then also possibly run IV fluids as well. Lidocaine, that's that medicine that they use to numb up the perineum if you need to have a repair done. So it comes in a little bottle and they use a syringe and a needle to administer that into the area. And then there's also other medical supplies, gauze, gloves, anything that you would think that you would need in that space. And of course, their experience and knowledge. So these providers, they are certified in neonatal resuscitation. They have to take trainings once every 2 years. They're also certified in CPR. They keep making sure that you vet your team. They should have a valid license. They should be in good standing with the state. Make sure that all of your I's are dotted and your T's are crossed. Also, as a caveat, it is very important that if you're having a home birth that you adhere to your midwife's supply list guidelines. So almost every home birth midwife will have a sheet for you that they want you to have those supplies by the 37-week home visit appointment to make sure that we've got everything. In those supplies are things like the cookie sheet, the hose for the tub, the towels, all the different like diapers, things for diapers for you, not for baby. Things for the postpartum visit for baby, like lancets and things like that. So it's really important that if she puts it on the list, that you make sure that you have exactly what they've said on the list, so that they're not thrown off the day of birth and that we've got everything we need. There's a reason for everything, I promise. Okay, so let's talk about what an out-of-hospital transfer can look like. So there's two different types of transfers, non-emergent and emergent. So if you're at home or if you're at the birth center and you're having a non-emergent transfer, what it would look like is, let's say we've noticed that baby's heart rate has been dipping for the last 2 hours or so, or their like baseline is just a little bit lower than normal. It seems like they're a little stressed. Or let's say that mom is like, you know what, I think I'm done. I would like to go get an epidural or something like that, but we're not necessarily super far along in labor. So for like anything less than 8 centimeters or so, you would probably be transferring by your own vehicle. So you would get your own vehicle, you and your partner would go in that, and you would go to the hospital. Depending on your provider, they would go with you in their own separate vehicle. But once they get to the hospital, you have now transferred care. So you have transferred out of the midwife's care and into either the OB/GYN on call or the midwife on call at that hospital. Your midwife should be calling ahead and letting them know that you're coming in either situation here. But just know that you have now transferred out of your midwife's care and they're not the ones helping you make decisions for that. They can go and still be a support person, but if they do not have privileges at that hospital, which some home birth midwives do, but not a lot, if they don't have privileges at the hospital, then they can't continue your care there. Other home birth midwives won't come with you to the hospital. So it's really important that you talk to yours and know what their protocol is for transfers. Emergent transfers are when we're calling 911. So that's things like those cord prolapses, maternal hemorrhage, resuscitations that are prolonged, things like that. So we would call 911. We would have an ambulance come to either your residence or the birth center, and you would go by ambulance. Typically, you're allowed one support person in the ambulance. So either that's your provider or that's your midwife, just depending on the situation. Usually, if we have had a baby by that point, baby can just go right on your chest in the transfer. It just kind of depends on what's happening. If it's mom that needs the transfer, then dad might take baby and put baby in the car seat and like take their personal vehicle, and the midwife might go in the ambulance with them. It just kind of depends on what's happening at the time. And like I said before, just know that maybe if we are having an emergent transfer, it's possible that people in your team might need to help either call 911, get the ambulance to the residence. They also might need to help with bags and getting things packed or getting people ready to go, getting mom like a robe on or something if she needs that, or getting baby clothes. It's really important that if you're planning an out-of-hospital birth, that you have a go bag packed just in case. I always say make a transfer plan and then just tuck it away in your brain, but you want to make sure that you have a plan just in case. You want to know what hospital you want to go to and where those things are. And then, put that in your to-go bag, or some midwives have you put it on your fridge or what have you. So just make sure that you're talking through these things with your provider. Okay, let's talk about inductions and cesarean section birth. So let's talk about inductions first. What are some possible necessary reasons for an induction? Like we talked about before, preeclampsia, hypertension, that high blood pressure, or eclampsia. Pre-labor rupture of membranes with no labor after 72 hours might be a good idea to have an induction after that, depending on your case. Or things like uterine infection. If your provider notices that you're having an infection, that could be a reason that we would need to do an induction. There are other medical reasons as well, but these are just a few examples. But really what I want to talk about are what are some unnecessary reasons for an induction. Going past 39 weeks. We know, because we've done our homework, that a normal pregnancy is anywhere from 37 to 42 weeks. So there's no reason to do a 39-week induction and not let your baby come when they're ready. Your provider's calendar. This also includes midwives. Okay. So some people will think, oh, well, I have a home birth midwife, so they don't take vacations or whatever, but I promise you they do. So their calendar, your midwife's calendar, your OBGYN's golf game does not necessitate an induction for you. I know a lot of people who will get inductions because their favorite provider will be on staff that day or whatever. I can tell you that inductions sometimes take 3 days. So you might not even have a baby on the day that you thought your provider was going to be there. They're long and they're hard typically. So, well, depending on where you are and if you're ready to have a baby. And then big baby. We know from research and evidence that inducing for a big baby does not necessarily increase our risk of positive outcomes. So if your provider is telling you that you need to introduce because your baby is huge, that's usually not a reason for an induction. Also, just know that ultrasounds in the 3rd trimester can be off by 2 pounds on either direction. So they could tell you that you have a 10-pound baby and then 8-pound baby or a 7-pound baby comes out. It's really hard to tell how big your baby is based solely on an ultrasound. So what are some differences between an induction and physiological labor? You have continuous fetal monitoring. So like I said, you'll have like the Doppler intermittently at home or even at the hospital sometimes. You can have intermittent monitoring, but if you're doing an induction, you'll have continuous fetal monitoring once they start any kind of medicine. So if they're doing Cervidil, Cytotec, or Pitocin, then you would have continuous fetal monitoring because those can have adverse reactions for the baby. It can stress your baby out. So they want to make sure that they're reacting okay to things like Pitocin. An IV catheter. So you would have like a little port put in your arm or your hand that would have the IV catheter that's ready to go. If you're getting Pitocin for an induction, your Pitocin would flow through your IV. Also, fluids would be given with the Pitocin as well. So you would have that set. Typically, you have less range of movement because you are hooked up to those things, or you're being messed with a lot more. Staff's coming in a lot more, adjusting monitors, doing those things. You'd be in a hospital environment, of course, so that comes with things like the beeping and the machines and the staff and the bed and things like that. Different from what you would if you had planned an out-of-hospital experience. Increased risk of needing pain management. So Pitocin, which we're going to talk about in a few slides, is very different than your natural hormone of oxytocin and creates harder, longer, faster contractions. So it increases the risk that you would want an epidural with those contractions because they're not necessarily natural contractions that your body would make. And then typically more staff are associated with your birth. So because you've had these interventions, you might possibly have like NICU team on standby, depending on what the scenario is, or you might have a few more nurses in the room as baby is born, just because of those other variations. So let's talk about, that's a medical induction in a hospital. Let's talk about 2 different types of induction, because there are also natural inductions that some providers will offer to you in the out-of-hospital setting. So a natural induction method first would be the evaluation of the Bishop score. The Bishop score is when a provider does a vaginal exam on you and looks at things like your effacement, your dilation, where your uterus is located. Is it posterior? Is it anterior in the front? They look at all of those things and they kind of give you a score of how likely it is that an induction would actually work. So some people, if you are 0% effaced, 0% dilated, literally nothing's happening, and we're trying to induce you, that is a lot different of an induction than someone who's like 4 centimeters, 90% effaced, and like just isn't having contractions. Those are 2 very different scenarios where your body might act very differently. So they would evaluate your Bishop score and kind of make a plan from there. So in the natural induction methods, sweeping of the membranes is an option. So this is when your provider would give you a vaginal exam and they would use their fingers to detach the amniotic sac from like that cervical opening and kind of stir things up is what they call it. This can release prostaglandins, which can help with effacement and can help trigger contractions as well. Now, it doesn't come without risks. The risks of sweeping the membranes is they could accidentally break your water, just like any vaginal exam, but more so because they're mixing things up. And it also has the increased likelihood of introducing bacteria into that area as well. So increased risk of infection. Next is nipple stimulation or using the breast pump. So you can use a breast pump. Don't go run out and do this just because you're 41 weeks and 5 days. But with the guidance of a provider, you can talk about using a breast pump to do nipple stimulation, which again releases that oxytocin, just like breastfeeding does. Not as much as skin-to-skin breastfeeding, but can release oxytocin, which can then create contractions for you. So sometimes nipple stimulation will be offered in the out-of-hospital setting. Castor oil is something that you take orally. It's an oil that helps with constipation. So a lot of people report that it gives you very loose stools or could even possibly give you diarrhea depending on how much you take. You definitely would want to take that with the guidance of a provider, but that can kind of, the reaction of your bowels can kind of trigger contractions in the uterus as well. So that is also an option, but again, that doesn't come without risks. And then breaking your water, something that we've talked about before, but is also another way that you can do an induction method. You wouldn't want to put this as an option for anyone before 4 centimeters that wasn't 4 centimeters already. Also, we know from evidence-based birth that just solely breaking your water does not show significant numbers in the research of increasing your time or like making your birth go faster if it's not accompanied with other things like Pitocin and other types of augmentation. So just breaking your water might not necessarily make things move faster. Okay, and then the medical induction methods, again, that evaluation of the Bishop score to kind of see what's happening. Then you'd be offered misoprostol. So this could be either Cytotec or Cervidil, which are 2 different medications. One of them is a pill that can go in your mouth or be inserted vaginally. The other is, it looks kind of like a tampon, and it's inserted vaginally and it just kind of sits in the vagina and releases the medicine, the Cervidil. Both of these are prostaglandins. So again, those would help with effacement and thinning the cervix out. Sometimes if you're very close to having a baby, it can start contractions and like all you need is the Cervidil or the Cytotec. Sometimes you do like 5 rounds of Cytotec to become effaced and still we're not in labor yet. So then we start Pitocin and like go down the slope. And then Foley catheter is another option as well. It's also called a balloon catheter. So it's it looks kind of like a balloon animal balloon. It's a catheter that goes into the vagina and then they insert saline and make a ball at the end of the catheter that sits on top of the cervix. And then typically there's a ball underneath the cervix as well. And it manually dilates your cervix. It can be quite uncomfortable. It can increase risk of infection. And it only manually dilates the cervix to about a 4, and then it typically falls out. So it doesn't necessarily mean that it's going to start contractions for you. It just means that it will like stretch your cervix out to a 4. And typically that's in for quite a few hours before that happens. It doesn't just balloon up your cervix. It takes a while before the Foley bulb will actually come out. And then we move on to Pitocin. So this is synthetic oxytocin, which we're going to talk about in the next slide, but that would be given to you through an IV, creates contractions, longer, stronger, harder contractions. And we're going to talk about the pros and cons of that in the next slide. And then, of course, breaking the water as well as a medical induction, which I just told you about with the natural one. So you know all that info. All right, so oxytocin is naturally occurring in the body. It's produced during labor to induce strong, long-lasting, frequent uterine contractions. Pitocin is the synthetic form of oxytocin through the IV and speeds up labor or decrease the time between contractions. So Pitocin doesn't cross the blood-brain barrier. So if you're having these longer, stronger, harder contractions, your body isn't really registering it in its brain. When you have oxytocin, your natural hormones, it creates endorphins along with the oxytocin to help with the pain management. Pitocin doesn't do that. Your body doesn't increase the endorphins as the Pitocin increases. So your body is not making those pain fighting hormones for you. Also, it can overstimulate the uterus as well. There's a reason why oxytocin works and why your body has contractions at specific times and at specific amounts. And when we use Pitocin to try to augment that, sometimes we can wear out our uterus before it's ready to have a baby. And sometimes if we wear out the uterus, it just stops contracting altogether for us. So just know that that is a potential side effect of the Pitocin. So potential side effects, longer, harder contractions, hyperstimulation like we just talked about. Because we are hyperstimulating the uterus, that can cause decreased oxygen to our baby because we're not giving our body and our uterus time to relax in between. We're just squeezing baby. So sometimes that baby can react adversely to the Pitocin because of that, and then we'll see the heart rate dip. Decreased freedom of movement during labor and continuous fetal monitoring, possible links to postpartum mood disorders. So there are some studies out there that show that it's linked to postpartum depression, and increased risk for an epidural, a C-section, and adverse outcomes. Okay. Let's talk about cesarean section birth now. Okay, so some possible reasons for a planned cesarean birth would be if you choose to have one for a breech baby or a transverse baby, placenta previa. So that's when the placenta completely covers the opening of the cervix. That would be a reason to have a planned cesarean section birth. If you are someone who has STIs, sexually transmitted infections that would be present during the time of delivery, that would be a reason to have a cesarean section birth so that baby isn't going through the birth canal through the STIs. Multiples, you could choose to have a cesarean section birth with twins, triplets, etc. There are some providers that do vaginal multiples or even home multiples, but that's something you'd have to check with your provider with. And then medical complications for mom or baby. So anything like those preeclampsias or eclampsia that we could see kind of building, the gestational diabetes, cholestasis, things like that. Okay, possible reasons for unplanned cesarean would be placental abruption, cord prolapse, fetal distress, like severe fetal distress, or sudden medical complications in mom or baby. Can be some reasons that you have a cesarean section birth. So what to expect with a C-section? You would have regional epidural or general anesthesia. So typically they would like to do the epidural first so that you can be awake during the surgery. But sometimes the epidural won't take, or if it is a severe enough emergency, if they're working fast enough, then it's possible that you would go under general anesthesia. So you'd be completely out. An IV or bladder catheter would be inserted into the urethra so that you wouldn't be going to the bathroom. You would be just going through a bladder catheter. A screen would be placed in front of you to keep the surgical field sterile. So you would go into the operating room and either be placed or lay down on the operating table. And that's when they would put up the surgical field. You can ask for a clear drape or a drape that has a window in it so that you can kind of see what's happening on the other side. Lots of hospitals have that option at this point. Usually only one person may accompany you. So if you have hired a doula, it's possible that they will not be let into the operating room. It would probably just be your partner. It completely depends on the anesthesiologist. So the anesthesiologist is the person that decides how many people and who can be in the room. So that's something that you could leverage for, but may not get if you want more than one person, or if you've hired like a birth photographer or something like that. You would definitely want to have a conversation with the anesthesiologist prior, if possible, to ask if they can come into the operating room. So the OB cuts through 7 layers to your baby. After baby is born, they usually go right to the warmer while the OB begins your internal stitches. So the OBGYN will cut through the layers of skin and the uterus to get to baby. And then baby goes, you might like see baby over the drape or through the drape. And typically baby would go right to a warmer that's in the operating room that you can see, you can look over and see. And a nurse would assess baby, make sure that everything is okay. And then they would bring baby over to your chest. Typically they're wrapped up in the blanket and the hat because it is colder in the operating room, and they would place the baby on your chest while you're still being worked on and getting everything closed up. Your incision will be closed. You do want to make sure that you've asked for a transverse closure. So you want your scar to go left to right or hip to hip, not up and down, because if you would like to have another pregnancy, another baby, and you would want to try to do a vaginal birth, a transverse scar has less associated risks for VBACing than a vertical scar does. And you and baby will be taken to a recovery room after, where you're going to be closely monitored. So they would put baby on your chest after everything's all stitched up and done. Then they wheel you into the recovering room together. You might be feeling groggy and sleepy from the surgery. It's possible you would also be feeling nauseous or need to throw up. It just kind of depends on how you react to the medication. Breastfeeding and the golden hour is still encouraged. So a lot of women will still be awake after the surgery, and they'll encourage you to latch your baby and have that first breastfeed. However, just know that it's okay if you and your baby are both a little sleepy afterwards. Remember, you are getting those IV narcotics through the epidural. So it's possible that you would both be just a little woozy afterwards, and it might delay breastfeeding. Usually within 6 to 8 hours, you'll be encouraged to actually get up and walk. And then the recovery from a cesarean is much different than the recovery from a vaginal birth. So you would want to make sure that you've got some things in place, lots of support for when you are home. It's possible that your partner would need to take a little bit more time off of work to kind of help you. And remember, it's going through those layers of the abdominal and the skin. So it's hard for you just to like get yourself up out of bed. So you might need a little help, extra help doing that. Having things like a belly binder can be really helpful to help your incision and put some pressure on your incision. And it's just a little bit of a different recovery road from a cesarean section as opposed to a vaginal birth. Okay, let's talk about the cascade of interventions. So first of all, I want to say that I'm not demonizing interventions. I think everything has a time and a place and a useful use of it for sure. That's why these things have been invented. But it's important to know that those interventions put you at risk for the next step in the intervention pipeline. So it's really important to ask the benefits and risks of any kind of intervention that happens. So for instance, this is a chart that kind of shows you the cascade of interventions. So our intervention at the top left corner is an induction. So we've decided to do an induction for, let's say it's because you're 41 and 5. So you're 41 weeks, 5 days, and your provider has been like, you know what, I think we should just go in and get an induction. Well, deciding to do that induction puts you at a higher risk for having your water broken, artificial rupture of membranes. That then in turn, having your water broken puts you at a higher risk of infection and also puts you on continuous fetal monitoring. Putting you on continuous fetal monitoring increases the risk for restricted movement and instrumental delivery. So then instrumental delivery puts you at a higher risk for fetal distress, hemorrhage, separation of parent and baby, reduced bonding, delayed nursing, problems with nursing, and so on. So as you can see, making one decision isn't really making one decision. It's also opening the door or opening the windows. If you open the door to the intervention, it's also opening the windows to the next step in the intervention pipeline. So that doesn't mean absolutely never do any intervention, but it does mean make sure that you have the full scope of what can happen if you do indeed decide to do things like get an induction, have a membrane sweep, break your water, get an epidural. All of these things come with increased risks of the next step. So it's really important to talk to your provider and know what those next steps are. Okay, so I also have in this class 2 birth videos. The first one is a home birth where they do a transfer of care at the end after the birth. So I think it's a really good one to watch during this class, and then which will be linked in the show notes or will be linked in the email. And then I also include a video of a home birth resuscitation. So this is optional if you want to watch it, but I think it's a really good idea to see how a birth team resuscitates a baby in real time and kind of takes away some of the scariness and the stigma of it. So look at both of those videos, and I will see you back for next class 4, where we will go over postpartum and breastfeeding. Have a great day.